Okay, so my talk, and I'll finish this quickly before we have has been discussed by most of us, but I just want to put the perspective of high risk and what is happening in CHIP. So CHIP is a rapidly growing field because with an aging population, development of advanced PCI techniques, increased MCA support, the percentage of CHIP has increased in contemporary practice a large amount. But the whole concept of CHIP is a little bit ill-defined with variability among operators, and everybody seems to think that something is CHIP. It's established the parameters and truly define CHIP so that we can reasonably create a risk score to avoid complications for CHIP. And if we looked at CHIP, we have three components. Unfortunately, many of the times we discuss the first, and that is the coronary anatomy, the location, the complexity, and the procedure. While the other two issues are extremely important, I'll tell you why. Comorbid conditions and concomitant cardiac disease, like structural disease, left ventricular dysfunction, heart failure, these, in fact, are even more important in a CHIP case than the first, where we spend most of the time discussing. So this we have discussed again. And unlike a risk assessment for a CABG, where we have a classic scores, which is the STS score or the Euroscore models, they have been validated. Unfortunately, we don't have such a clear risk score for CHIP. And most of these are very less robust. Now, the syntax is a popular system for PCI, but clearly it is based only on angiography and anatomical parameters, and it has nothing to do with the other two major issues, which is the left ventricular function and the associated comorbidities. And hence, to provide cutoff values in tertiles to help to guide the decision of revascularization strategies in PCI and CABG in complex patients with LV dysfunction is very difficult unless we standardize the whole thing. I think if anybody has to read anything in a CHIP, please read this paper. It's the most useful paper in terms of risk assessment and reducing your risk in the cath lab. This is in JACC Cardiovascular Interventions in 2022 from the British database of the cardiovascular intervention data of all PCI procedures done from 2006 and 16. And it's a beautiful multiple logistic regression model which was developed to construct the first time a good CHIP score which will target your Mason-Nace events. Why this is important? Because this data has 300,000 patients who underwent this procedure in UK, underwent complex, what we call as a CHIP procedure, and it looked at the risk of in-hospital cardiac outcomes, not only procedural complexity. And it includes, for the first time, both the procedure and the patient. And this is extremely important when you look at it. I will go through these risk scores, but let me just go through it word by word because it's important. Now, when you look at such a multivariate adjusted baseline, most of us don't look at it beyond 2 seconds and say, okay, you know, we have some risks which seem to be important and some risks which is to the left and an odds ratio on the right. And you can look at here that the odds ratio in the right is what's going to determine your procedure. And what is very important that the odds ratio for the coronary anatomy and the procedure only starts somewhere here. That is the left main PCI and rotational atherectomy. Everything else seems to be not related to the procedure. It seems to be the patient. Renal disease, EF less than 30, upfront LV support, you know, and what is more important is as your CHIP score goes up, you know, you see that the patients in the United Kingdom, 30% of patients have CHIP 0 score. And almost 70% of the rest of the patients are having a high CHIP score. So we're going to getting into a time frame where more and more patients are getting a high CHIP procedure. And I looked at my data for the last 10 years, and it was exactly the same. 35% was CHIP 0 score, 65% was high CHIP scores. So out of 900,000 patients, 300,000, that is 30% of the patients, were the high-risk CHIP scores. And we had 7 patient factors, and I think this is important for all of us to put it in your into your phone. Age, women, previous stroke and MI, peripheral vascular disease, ejection fraction less than 30, and chronic renal disease. The 6 procedural factors are rotational atherectomy, left main 3-vessel PCI, 2-axis, which invariably comes in the CTO, mechanical support, and a long length of a lesion. And these were clearly involved in MACE and the CHIP risk factors. Now, what is important is this slide. If you looked at planned LV mechanical support, it had 3 points. Age, 80 years, peripheral vascular disease, EF less than 30, chronic renal disease had 2 points. And all the others, which is whether you use rotablator, whether you use ELCA, whether I debulked, I didn't debulk, I did CTO, I did what, was 1 point each. So what is important is that mechanical support and your comorbidities are going to determine your outcome. And this is extremely important because you see, look at the odds ratio of a CHIP score of 1, which was in 2006, has moved to 1.5 in 2016. But you look at planned LV support, patients are 0.7% has gone up more. And what is very, very important is this. If you have no CHIP, your in-hospital MACE is 0.6, your bleed is 0.3, your in-hospital mortality is 0.1. Just go to planned LV support, 15% becomes your in-hospital MACE, in-hospital mortality is 11, 6.6 is your major bleed. Simply taking a mechanical support in changes all outcomes. And this is very important. It could be biased because you use support in the sick patient, therefore maybe that patient gets sick. But it's also important for us to understand that don't use a mechanical support if not required. And this has been shown clearly in many of the studies that say ECMO in cardiogenic shock. JAMA paper says worse outcomes. So clearly don't open a procedure and start doing a procedure with the support because you're increasing the event rates by increasing the bleeding. And so it's very important that you dictate what you're doing before you start the procedure. And in the same form, CKD, you can see that CKD clearly risks your events and mortality. It's important to manage renal problems during a PCI. I'm glad that this had a CKD-related issue. We had bleeding issues being discussed, which is normally not discussed. And you can see as the risk score goes up, your MACE goes hugely up to 19.5. And it's sort of, you can easily remember this. If your score is up to 5, your events are below 5. If it goes 5 to 10, your risk becomes 10. And if your score is above 10, your risk goes more than 10. So 5 for less than 5, 10 for 5 to 10, and more than 10 for people who are. So I'd like to say that in-hospital MACE is low if you have no CHIP factors. Any one factor makes it double. Steeper rises start at 5, and it just doubles as it goes. And above 10, you have catastrophes. You better be careful when you're taking these patients in. So I think the clear number is the score and the mortality. But one should not forget bleeding in this whole issue. As somebody nicely pointed out, the risk of bleeding is double now of stent thrombosis in the patient. Because stent thrombosis is becoming lesser and lesser while bleeding is getting bigger and bigger because you have better and better antiplatelets, stronger and stronger antiplatelets and anticoagulant. So to get a CHIP score not only increases your mortality, but it increases your bleeding. So you have to be very clear when you're managing these patients that you have to pull off your antiplatelets or anticoagulants at the right time, moment the ischemic risk is down. And this is extremely important that we understand that the CHIP score is extremely important to be evaluated before you jump into the procedure, not just discuss the syntax score and jump into the patient without knowing. I'm going to give you simple points how you can reduce this. One is vascular complication. Now you should use an ultrasounded guide puncture. And this is extremely important. If you have people skilled, in femoral access through ultrasound, your problems will decrease. And it's important for cardiologists to learn ultrasound for this reason. We have not had a single retroperitoneal bleed in the last 5 years once we shifted to two techniques. One is micropuncture, which is either ultrasound-based or by an opposite side. And especially when you move into TAVR and stuff like that, or difficult large bore accesses, I think is extremely important. The punctures are good. In an era when your fellows are doing 90% of their procedures radial, unless you train them to do this, you're going to get into a major complication without that. I think one thing is radial procedures, very good, but complex procedures, many of the times, especially with large bore access, you have to go femoral, and you have to use ultrasound or micropuncture guided through either angiography or ultrasound. So you always do it this way. No change in a strategy on the table when you do femoral access, either ultrasound or opposite side puncture. The second technique is the moment I see calcium, you do two things on the coronary. You need to do an imaging, and if your patient is, you have to strategize your debulking procedure. Now, without doing the imaging, you don't know what to do, but we have to be prepared. How do you get prepared? You got to get your guiding correct. You got your access correct. Many of the times you go radial, but sometimes you got to go femoral because you may be thinking of two-stent strategies where you don't want to struggle with the radial. And you need to plan. Am I going to start road ablation? Am I going to use cutting balloon? Am I going to get IVL? Because all these things have to be on the table before you start. Now, this is a patient, well, we discussed very complicated procedures, but here is a patient with a left main tight. We use about 500 intra-aortic balloon pumps a year in MMM, but I have used only 4 impellers, to be very honest, and the reason is the cost. I understand impeller is great, but cost is, but I don't think we're compromising too much. Today we saw Shadad showing a classic case where impeller was beautiful and IBP would not help. But most patients you can get away with a good intra-aortic balloon pump, at least for non-MI patients and at least for pre-procedure treatment. So put it up front, get in your anatomy clear, getting your road ablator bars ready, fixing your bars up. Sometimes your bars won't cross. With 1.5, you have to downscale your bars, go up on the rates, and these all have to be planned before you go in. Reducing your chip complications and improving your outcomes is how you plan the procedure. And without imaging, and I'm going to show you only IVUS, not because I do only IVUS, but OCT has one issue in chip of dye injection, especially with patients with CKD and LV dysfunction. So we use more IVUS. But it's important that we do it pre and post. I do not agree that we should do it only post. Because this sort of calcium, you will see clearly only with pre-posting. We also know the lengths. We can plan where the overlap of the stent happens. We should not put an overlap of 2 stents at big side branches. We should know the sizing because always is a taper. So 2 stents is better than 1 extreme long stent, especially when you're dealing with left main. I think it's important to do this strategy before you go in. You have to size your reference vessels, you have to measure your lengths, and plan the procedures correctly. After which, you do the second one, and you saw calcium despite road ablation, and what you need is to go in with a plan with a shock wave, and you do multiple shock waves, and then the procedure becomes standardized. I'm not going to go through the procedure, and you get wonderful results if you plan this right, with road ablation, shock wave, and high pressure balloon with IVUS guidance and end of the procedure. You have the right side, which is as bad, and here you again get in down with again measurements. You bring in the lithotripsy, do it multiple cycles, open it all up, and get a final result. Again, end with imaging, so you're damn sure you've achieved all good results. We saw perforations. You have to have all sorts of covered stents on your shelf. This is a graft master, which was creating it's a perforation, impeded pericardial tamponade. We tried ballooning. This is another one case, and we saw all this. I'm not going to go through it, but you need to have sometimes difficult, different. That was a papyrus going down. Sometimes a simple thing like a tracking of the wire. Now this looks very harmless angiogram. We would have said, oh, what is the problem? My wire will go down the LAD. It just wouldn't go down the LAD. It'll always go down the septal, the wire. I changed multiple wires, multiple curves. There was calcium on the top border of the LAD, which proximal to the lesion, and every wire would go down the septal. So I took a Asahi Sasuke trying to cross. The Sasuke wouldn't take that curve at the proximal part, at the lesion, and I couldn't get it down. So what we simply did, we changed over to a supercross 120 angle, and then it crossed. See that angle with calcium? Sometimes you need to have all this stuff on the table, and you need to have different microcatheters to cross and fix it. You need to have the telescope there, or any guideline or Godzilla to get your stent down, and you should be very conversant with the sizes and what they will take, because you can't get something in and say, oh, now this is not going to track through. This, this thing will not go to a 5 French. We now need to upgrade to a 6 French guideliner. So these are all to reduce your complication. This is another problem. You start calcifications, and one day you will get a stent dislodgement. And then you have to be ready with everything, what to do. Here was a stent which got dislodged, pre-dilatation done. One of my colleagues went down to this, and the stent got dislodged with the balloon. Now we need to be ready what to do in this situation. So your various ways you can intertwine did not help, but you have to have your micro snares there in the cath lab, catch the thing, bring it down. Now you're more sensible. You go down to the rotablator next time, and using cut it, stent it, and do the procedure. Finally, dye is an extremely important part of your procedure in CHIP. And if you don't restrict your dye, you're going to come with AKI and complications. Most of these patients have low eGFR, and you're going to get into trouble. This is a zero contrast large study we did of 72 patients, which we published in International Journal of Cardiology. And I think you can do many times zero, but at least low contrast is possible. And we are now running a randomized study on this story in patients with CHIP cases. So this is what I can conclude by saying that CHIP is a planned procedure. It has not only to do with the planning of the procedure, it has to do with the planning of the patient, his kidney function, his LV function, your plan of your support devices, and you go in with a clear plan with an exit. And you need to have the surgeon around. You never know when you'll get into trouble, and start it always as your first case. Thank you very much.
Thank you, Dr. Ajit. The messages are very clear, and I think it summed up. I was wondering whether you should have started the session also, but it's very clear and loud, and we know the take-home messages are very clear. Any final words from Dr. Trihan? I think everything is done. Dr. Manjuran, any comments?
I think you have summarized very well. The CHIP cases, the risk is mostly lesion-related, the patient-related, comorbidities-related. Nowadays, the main problem is that most of the patients who are coming for intervention have one of these problems. Either they may have complex lesion, or they may have comorbidity, or they may have some heart failure, or some of these problems may be there. So that is the big challenge. In your experience, what would you say that the percentage of cases which does not have any comorbidity, does not have any complexity?
So the BCIs, when it was published, I looked back at the last 10,000 PCIs over the last 8 years we did, and 35% had CHIP 0.
Yeah, that's
65% was more than CHIP 1. And I think there was 22% were above 5. So really we're going to get into trouble in these patients, either problems with kidney, problems with age, problems with function, or problems with the anatomy. So we need to be clear that we are very careful in these patients.
And moreover, we are getting the patients who are more aged. That also, most of them will have some comorbidities. Any comments you want to? Okay, I think he has done a wonderful job. I'm sure all of you will agree with me that it was actually a summarization of the program that we had. Any comments from the audience? Otherwise, we'll call it, we'll close the session. Any comments?
I think we'll close.
Yes.
I think we'll close the session. Let's give him a big hand.
Thank you very much, sir.